friends, Pradeep Pindyala, Professor of Anesthesiology. Today I am going to talk very briefly about difficult airway, especially when you are dealing with syndromic children. Well, difficult airway, as you know, is a clinical situation which is where the conventionally trained anesthesiologists experience difficulty with face mask ventilation of the upper airway, and there would be difficulty with tracheal intubation or both. Well, as you are aware, difficult laryngoscopy is estimated in around 2% of pediatric children. More so, especially in congenital syndromes, they are associated with huge difficulty in intubation. When you talk about congenital syndromes, the first thing which comes to your mind is Down syndrome, then Treacher-Collins syndrome, then probably Golden syndrome, Klippel-Feil syndrome, and Pierre-Robin syndrome. I'm sure you would know all this. I'm not going to explain all they are. And Hurler and Hunter syndrome also considered difficult airway conditions, ain't it? Well, airway assessment in a child is definitely very difficult because of lack of understanding and cooperation. And children are different. Most of the parameters are subjected very differently. Like, it's not all that easy to look at or elicit a history of obstructive sleep apnea or the previous intubation difficulties, or to look at the uvula, range of neck movement. All these things are very difficult to assess in a pediatric child. But you can easily know history from the parents, history of noisy breathing, snoring, apneic episodes, and previous neck irradiation, or any airway surgery which had taken place, and this history can be easily elicited from the parents. Okay, well, now you have a child with syndromic child, one of those which I just mentioned, and you need to anesthetize such a child. It's bound to be anticipated difficult airway, and the presence of a senior anesthesiologist should, and it's a must when you are trying to intubate such a child, syndromic child. Okay, you're bound to have difficult airway, no doubt about it. Appropriate size airway should be readily available, and laryngeal mask airway should be available. Pediatric bougie must be available. Smaller size nasopharyngeal airway, uncuffed endotracheal tube must be available. Sedative premedication, better avoid. Antisyllagogues and nasal decongestant can be used definitely, and gradual induction with sevoflurane, and the preservation of spontaneous ventilation is a must. Okay, preservation of spontaneous ventilation when you are gradually inducting the child with sevoflurane is the method to be followed. Any airway manipulation should be attempted only when adequate depth of anesthesia has been reached. Okay, without adequate depth, don't try to airway intubation. Okay, once appropriate depth is achieved, then try to put the face mask and see you have attained good mask seal and you are able to ventilate comfortably. If mask ventilation and mouth opening are adequate, and try to do direct laryngoscopy or video laryngoscopy. In case of reduced mouth opening, try nasal fiber optic bronchoscopy. Okay, and if mask ventilation is not adequate, use head extension, jaw thrust, and two-hand manipulation, two-hand face mask placement and ventilation. In case inadequate ventilation is still present, insert a laryngeal mask airway, or then later you can try a fiber optic guided intubation through the LMA. So that's that. Thanks for patiently listening. Have a wonderful day. Until next time, take care. Bye-bye.